So when in my practice do we use fat grafting? The instance that I most commonly do fat grafting is after breast cancer reconstruction. After we either put in an implant after a mastectomy or do a flap, there can sometimes be a hollow around the implant or a little bit of a divot because the implant or the flap doesn't always fill out the entire mastectomy space. So fat grafting can be helpful. This will involve a surgery under general anesthesia in most cases, harvesting fat usually from the front side of the body. The abdomen and the upper inner thighs tend to be the best donor sites. That fat is soft and squishy, and it's usually easy to remove, and that way we don't need to turn our patient during surgery. We harvest the fat using liposuction. We keep it sterile, and we often wash it with saline and sometimes some other solutions, and then we end up having additional fat in several syringes, and then we inject it somewhere else. When we inject it around a breast implant for breast cancer patients or around a flap, we can only rely on about 30% of the fat cells surviving, which means patients are going to love their donor site. They'll have a flatter belly or less fat in their upper inner thighs, and they may notice a little bit of a benefit, but again, most of the fat cells go away. So fat grafting is a good adjunct for breast reconstruction. It's not magic. You cannot create an entire breast with one session of fat grafting, and on occasion, we will do serial fat grafting procedures, usually separated by 3 to 6 months. Each time we do an additional round of fat grafting, we might have a little bit more fat survive, but it's usually in preparation for putting an implant in or to smooth out the transition between the chest wall and the breast reconstruction.